For many people with systemic sclerosis, Raynaud's is often one of the first presenting symptoms, and it's a condition affecting the vascular system. However, to date, I think it's fair to say that treatment for systemic sclerosis has focused mainly on the fibrotic nature of the disease. But for some years now, Professor Marco Matucci has been working with colleagues questioning whether the vascular aspect of the condition should be given more consideration with a view to even earlier intervention. Marco is Professor of Rheumatology at the University Vita Salute San Raffaele in Milan, and I hope I said that correctly, and is a widely published researcher. He's president of the World Scleroderma Foundation and a great friend of SRUK's. So I'm really honoured that Marco is here today to share his really, I think, exciting work.
Thank you, Sue. And it's a great pleasure to be here today with you. Also a great honor to present to you the last 20 years that have gone very fast, but that has taken our community to expand the vision on what is in reality the disease and how the disease moves and evolves in time. So that's the reason why I call this a journey of 20 years. These are my disclosures. And you know that scleroderma is a heterogeneous disease. We have patients that are almost all the same, but in reality, when you look at the clinics, they are very frequently different one from each other. You know that we have the diffuse disease on the left, we have the limited disease on the right, different complications. Some seem very similar, but in reality, they can get also very rapidly in a very severe situation. This is something I have designed for you. This is called what I call the rose of the wind, but I call the scleroderma rose. Why? Because here you have practically everything you can see in a scleroderma patient. But what is important for us is the capacity to have the orientation into the disease and the disease evolution. You see here Raynaud phenomenon, RP. Then on the left here, PF, puffy fingers. On the right, NVC, nail fold video capillaroscopy. And here below, the antibodies, ANA and the specific antibodies. These are in red, and as much as I will talk to you, you will understand why I put these 4 items in red, because these 4 items in red have become so important for us in real practice, in everyday practice, because usually they are trying to guide us to the very early disease of scleroderma that we call VEDOSS, or VEDOSS if you want. Then around, in blue, you have the skin, you have the lung and the heart, you have the kidney, you have the gastrointestinal system. So you have the whole system, human system, working together and creating different areas of interest in the patient with different complications. So I have divided my talk in yesterday and my talk in today. But I want to make a premise because I strongly believe that what is today in reality is our future. Because whatever will be our future is decided today, not tomorrow. So the future of the patient is today. And today, we must be able and capable to understand, identify, and treat the disease accordingly with whatever we have in our hands. So in 1993, this was approximately what we knew about scleroderma. You see there is a steep here line On the left, this is the diffuse patient that are usually aggressive, rapid, and then it slows down, it goes down. But then below, you have a very low line that is characterizing the 70% of our population that are the limited patient. So for you to understand, when I'm teaching students, in order to let them understand what it does mean, I just make a simple example. You have, I say, me and one of my students, we are on the edge of the shore in front of the sea, and the waves are coming slowly and slowly and slowly. So we are there with our feet in the water, and the waves are coming slowly, slowly. Now, what makes the difference? Only because they are so slow. If I remain there half an hour, it's something. If I remain all the day and the day after there, my feet will be very much affected by this very mild water coming and tapping my toes. But if I'm on the shoreline in front of the sea, and abruptly arrives a huge wave and hits us, this is diffuse scleroderma. So we have two kinds. One that will hit the patient very rapidly, and the other one that will slowly in time make the damage, while we are just talking without even perceiving that this damage is done. So you understand, if we translate this in medicine, and this is what we have tried in the first decade, from 2000 to 2010, to understand in our community, because we knew that systemic sclerosis is very heterogeneous. We had a lot of confounders. We had a lot of diagnostic criteria, and I will drive you in what is the meaning of diagnostic criteria, because we had also other diseases like unclassified connective tissue diseases, mixed connective tissue diseases, what at those times were called pre-scleroderma. But all this was confusing the scenario. And we did not have diagnostic criteria. So, and you can ask me, but how did you make a diagnosis? I made a diagnosis because it was so clear that I could not miss it. But the meaning of so clear, it means it was too late, because it was evident on the hands of the patient, on the face of the patient. In fact, if you look at this slide, you may say, oh, what is going on here? Why in the 70s, the diagnosis was not delayed, and in 2000, it's much more delayed. Why? Because in the 70s, it was clear. It was clear that you had scleroderma because you were in such conditions that anybody could make the diagnosis. But in the 2000, we started to have problems because we started to consider Raynaud phenomenon. And we will look at the Raynaud phenomenon like stunned, because Raynaud phenomenon and antibodies and capillaroscopic changes. So what should we do? And we did not know what to do. We were like blocked on the starter blocks, but just blocked. So that's the reason why we arrived to this point. And as you may see, Professor Denton was with us in those times, that we call the challenge of early systemic sclerosis. And we thought that it was time to cut the knot that was keeping us blocked there and try to change the scenario, the perspective, in order to understand as much as we could the condition of the patient and to decide what we should have done in this early patient where we did not know what to do. But in 2013, we revised what we call the classification criteria. I have to clarify that the classification criteria are not diagnostic criteria. The classification criteria are mainly drafted to be used in randomized clinical trials. And that's the reason why we were missing the patient with the old 1980 classification criteria, but these new criteria were much more sensitive. They were able to identify even early patients with systemic sclerosis. So we know this, and we were proud of this, having done this new ACR-Euler criteria. So the evolution in 93 and 2013 allowed us to understand that we could intercept exactly the patient in these areas that are the areas of, I'm trying to see, a pointer, no, sorry. So you see the red and the rows down in the early phase of these lines to intercept this patient and try to treat them as soon as possible in order to abort the disease evolution. And in fact, this is a drawing we done in 2013, but you see that here you see the black area that is the advanced disease. You see the purple area that is the established disease, but then you see the early area that is intense red. So at this point we said, yes, we can intercept the patient in this early phase, but maybe we can do much better than this. Why we can do much better? Very simple. Because we could intercept the patient even before. And so started the quest for the window of opportunity. So do we have really a window of opportunity to catch, to find, to detect these patients so very early? And all this stemmed out from this paper. This is a very nice paper. This is 2008, our Canadian colleagues. And Jean-Luc Sénécal in Montreal, he worked on hundreds and hundreds of patients looking backwards in his experience. And he found patients with Raynaud phenomenon, and he started to see how did these patients evolved. And he found that those who had antibodies and capillaroscopic changes were those who, after some years, would have developed the disease. So he said, you know, these guys that have Raynaud phenomenon, antibodies, and capillaroscopic changes, they have a high probability of developing definite systemic sclerosis. Now, which is the point here? This work is very important. Why is it very important? Because it stimulated us to think and to say, I'm sorry, these patients don't have a very high probability. These patients are systemic sclerosis patients now, not tomorrow. So we ought to do something now. And for this reason, we thought that we had to change. We had to change our attitude. We had to change the approach. We had to take another direction. And from this, we started in the middle of difficulties. But this is in our profession is normal. those who said, no, this is not possible, why we should have diagnostic criteria, we had classification criteria, but we did not leave the position, and so that's the reason why we created the very early disease of systemic sclerosis project. So we tried to identify all patients with Raynaud phenomenon, antinuclear antibodies, with puffy fingers, and then going for modification of capillaroscopic nail fold around the nails, and abnormalities, and also the presence of antinuclear antibodies and specific antibodies. So all this package, we were able to demonstrate that we had progression rates over time. So those who had Raynaud phenomenon, and in particular antibodies and puffy fingers, were those who were more rapidly advancing to what we call definite scleroderma. And so this allowed us to design a riskometer. We did even the riskometer here, but also to have a behavioral flow chart of the doctors. Step 1, Raynaud phenomenon, puffy fingers, ANA. If you see this, whoever see this, doesn't matter who is the doctor, this doctor should send the patient to a reference center immediately. Don't wait. Don't waste time. Go. Because in the second phase, we go for capillaroscopy for specific antibodies, and the moment we find them, we know that this patient already has scleroderma. Even if you cannot even see the disease, the skin is almost normal. You have a little bit of puffy fingers, but nothing else. And after this, you move to the third level, when you go for internal organ involvement with the esophageal investigation, pulmonary investigation, heart investigation, and even if you want to do even the biopsy. So we enter in the diagnosis not anymore in the very early, you are already in the early disease, in the red stripe that you have seen before. So at this point, you may see that we added another phase, advanced, established, early, very early. So we open what we call, finally, we open the window. It's the window of opportunity. Because in this patient, in this phase, we could design an intervention to block the disease progression. But let's talk today. And today, we call it beyond scleroderma. Why? Because it took us 15 years to make those criteria that I've shown you for a very early diagnosis accepted by the community. 15 years. Not 2 years, 15. And think how many patients we have lost because of this. And we have lost them because we did not know what to do and how to behave. Why? Because we are linked to some methodologies that we all think are correct, but sometimes they're just a little bit slowing us. So today, what is today? We know that patients that have VEDOSS in reality may have other problems, esophageal problem. This was a paper we published in 2015, just showing how much they had esophageal and anal problem already. And we are seeing that in this patient, we already have some GI, gastrointestinal inflammation present. And that even the heart is involved, even the heart. This is a subclinical involvement. But when you look at these 3 cases with 3 different kinds of antibodies, 3 different kinds, all 3 patients had a damage, myocardial damage, that put them in jeopardy. And you see, on the left side, we have vasculopathy. In the middle, we have inflammation. On the right side, already fibrosis. So what does it mean? That practically we were in 3 different phases of the heart involvement. But these were considered early patients. And we also demonstrated that these patients have a subclinical, so it means you don't feel anything. But when you go to measure, you see that the pulmonary function tests are impaired already. So you know that despite you feel very well, you run, you go, you still are entering into an area, a gray area. So from this area, we see that the lung volume loss is already starting in this population. So practically from 1993 to 2021, where the criteria when published, the VEDOSS criteria, we have had a progression of knowledge of the lines that you see here, of the early phase in blue, in red, and in rose, but also appearing the area of the VEDOSS that is prior the early phase, because it's the very early phase, and then at this point we have opened another window. Because the other window is what is coming before the VEDOSS. What is before? And so we think that having identified a patient in the VEDOSS area, it's very important. But we are already thinking, and as I told you, the future is today. Is today. So we already have to think what is before. And so we arrived to what we call now the new challenge that we have in the community to identify what we call pre-scleroderma patient with precision and preventive medicine. And in fact, you see another stripe on the left, the white stripe, coming up. Do we have even another window of opportunity? Do we have it? Why I'm saying this? Because we have patients that have Raynaud, a little bit of Raynaud, and antibodies. They don't have the criteria for the very early disease. So what are these patients? And you can understand the responsibility that we doctors share in saying to this patient, okay, go home, doesn't matter. Okay, we will see in the next years what will come. Do you think this is correct? Or do you think we must do something now? Because this, what we do now, today, not tomorrow, will change the fate of this patient. So that's the reason why this is the next challenge we are having. And now just to recapitulate how our community has developed, and I have to tell you, we are the only one community that has done this in the last 15 years. The only one. Because this kind of procedure has not been done in other diseases, except a little bit in rheumatoid arthritis. So you see here, we were in the domain of the classification criteria that were drafted in 1980. So we were able to, let's say, classify, or if you want, diagnose some patient clearly. But then, in 2013, we made the ACR-EULAR criteria much more sensitive, so we were able to identify even more patients than what we were able to identify with the 1980 criteria. But then what came up? In 21, we arrived to amplify these rings with what we call the VEDOSS criteria in order to be able even to catch those patients that we were missing with the Euler criteria. And now we are entering into the world of pre-scleroderma. Because entering in the world of pre-scleroderma, and I'm sure I will not be there, means to understand what is coming before we see the minimal changes in a human body, despite being these clinical, tiny clinical changes or serological, hematological changes, because we will have to work a lot. And the question is, may we treat VEDOSS patients? And the answer, and I put here rheumatoid arthritis, that started much before us, but did not arrive yet, as we did, to some conclusions, because are we ready to treat VEDOSS patients? And the answer is probably yes, we can now. This is a trial that has been done with steroids, with cortisones, glucocorticoids, that was done specifically for the vasculature, but was not successful. And we know this also because steroid is helpful, but cannot solve the problem, like it's solving the problem in other diseases. So we have now a panel of drugs. We have immunosuppressors, we have vasoactive drugs, we have vasodilating drugs, we have antifibrotics drugs, and I have to tell you, at present, we have, I think, if I well remember, 25 randomized clinical trials with new drugs for scleroderma, plus 35 CAR-T treatment for scleroderma. 35. I was impressed when I read in the NIH the report of these trials, because our challenge today is how shall we position these drugs in the history of the disease? How shall we position these drugs in the patient characteristics and capacity that we have to predict? This was called before prognosis, predict the disease evolution. This is something, it's now really a tough problem that we have. How can we decide to treat this patient? So in the VEDOSS, there is now a new trial that will be prepared to go. It's called the SHIELD, that is promoted by the World Scleroderma Foundation. And we are choosing now the drugs to be used in these patients, while on the other, in the definite patients, clear patient, we are now speaking about combination therapy, double immunosuppression, immunosuppression, double immunosuppression, triple therapy, immunosuppression plus antifibrotic, still with vasodilating and vasoactive drugs. And you see that our complexity is finally getting to a very high level that we did not have, unfortunately, 20 years ago. Because the clock is ticking inexorably. And from right to left, thinking the disease is advancing, in reality, we are going backwards. We are going to the first areas, and we almost arrive to the point, that we are there, we are getting close to the very, 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 very early patients that we are going to call now pre-scleroderma. So we know that the VEDOSS patient should be diagnosed as soon as possible. We know that heart, GI system, and lung are already there, present, with modification, sometimes more dramatic, but not symptomatic, sometimes much less. And we know that we will have to decipher as soon as possible what means pre-scleroderma and what is going on in that phase of the disease. And also we need large-scale studies concentrating on the VEDOSS patient in order to move as soon as possible to the pre-Scleroderma area. I need to thank my colleagues on the left, Jérôme Avouac and Tunde Minier. They were the first young guys that led all the first part. Then Yannick Alanor, Oliver Dissler, Dan Furst, because they were those who really were the backbone of the whole project. Francesco Delgado, who expanded the project and made the project now very successful, and he will be the PI of the SHIELD trial. And also Alain Lescoat, here on the right, down, he's the youngest, but he's one of the brightest, that is opening the area of the pre-Scleroderma investigation. I have to thank also my colleagues where I work now in the Ospedale San Raffaele in Milano. And also I would just remember that we have also a journal, fortunately, that is called Journal of Scleroderma and Related Disorders. And I thank you very much for your attention.
I don't have a question, but I want to tell you about something that happened about 40, 50 years ago when I was a student nurse. We had a lady admitted who had gangrenous fingers, and she was complaining of abdominal pain. And the doctors were saying that she was making it up, basically. And I remember that she said to me, "You're the only person who's been kind to me." And she died the next day, and her gut was gangrenous. Her fingers were gangrenous. And I'm certain that she had scleroderma. And I think about her, still think about her all those years later. And her life would have been saved with the VEDOSS. So thank you very much.
Thank you. Thank you for saying this. Thank you, because this is reminding us of an area. As I told you, scleroderma is a heterogeneous disease, but in reality is one disease with different phases and phases. But there is what Sue mentioned when she presented me about vasculopathy. And this is really a case of aggressive vasculopathy that was not only limited to the hands, but unfortunately affected the gastrointestinal vessels, in particular the mesenteric arteries. So probably this led to the sufferance and the death of the patient, unfortunately. Please.
What a marvelous storyteller you are. Thank you for such a gripping talk straight after lunch. My question, do you think this horrendous job of finding the very, very earliest markers is going to be helped by the more widespread use of genomics and also AI?
Thank you. The question is, it's in line with our times. Genomics is something we are dreaming from ever. In order to identify the genes who are responsible for this, but we know, like in other connective systemic autoimmune rheumatic diseases, that we have polygenic diseases. So I don't know if we will be able to identify the genes determining the disease. Maybe we shall find the genes who are facilitating some specific clinical features of the patients. In this endeavor, we know that artificial intelligence would be fantastic if applied correctly to what we are doing. I can tell you, that results that I had 7 years ago that I submitted to artificial intelligence gave me the answer. Because my eyes, my brain has a narrow vision sometimes. But even if I am well educated, whatever you want, but it's so difficult to put things together and to give a sense to them. So for this reason, I think that artificial intelligence will help us enormously in the future if we are able to position all the data together and to analyze the data with the help of such a powerful tool.
I'm really sorry we don't have any time for any more questions.
Thank you.
Inspiring.